Is it important to have the patient sitting up when you're examining for that? Because I would imagine that potentially if you're using like a microscope and you have them laying down, could that mask the patulus? Because your kind of gravity is kind of potentially pulling, plumping up the eustachian tube, or do you usually see it when patients are laying down under the microscope?
Well, right. So at first, I ask, are you having your symptoms right now? Are you having the autophagy? If they say yes, I'll keep them sitting and I'll look with the otoscope first. Now, if I cannot see it, I may lay them down for the microscope and ask, did it go away? Yes, it went away. Okay, so now I know we're dealing either with patulus or possible semicircular canal dehiscence. Now, if the symptoms don't go away, then I continue with the microscope exam. And if the drum does move visibly, that's pathognomonic for patulus. If the drum does not move, and yet they have their symptoms, now I'm thinking that could be otocapsule dehiscence, semicircular canal dehiscence. The final test is when we go to a tympanometry, which we can get to in a bit, where we do a patulus test.
Mm-hmm.
Now, there's one other complicating diagnostic problem here. A lot of patulus patients actively sniff strongly to control their symptoms. And we've traditionally called this habitual sniffing. So I no longer think it's habitual sniffing. These are patulus patients controlling their symptoms with strong sniffs to try and get some temporary closure of the eustachian tube. They can sniff so strongly that they will generate negative pressures in their middle ear, even to the point of tympanic membrane retraction and middle ear fluid. So back to that original, here's the patient. I've got the blocked ear, I've got a hearing loss, I've got middle ear fluid, I've had lots of tubes. I look in the ear, looks retracted, there's middle ear fusion, obstructive eustachian tube dysfunction. But the patient is sniffing before your very eyes. Why are you sniffing? Oh, it unblocks my ears. The patient with negative pressure shouldn't be sniffing because that's going to make it worse. So I call that inappropriate instead of habitual. They're sniffing to control their patulus. So that sniffing habit is a giveaway. This is a patulus patient who's sniffing that strongly. And they can even cause a retraction pocket that progresses to cholesteatoma. They're doing it so often and so severely.